I'm going to shift gears now for just a moment. I'm looking around to see if Secretary Dooley has been able to join us. She's on her way, but she was called in earlier to the governor's office. Imagine that. She had to go help the governor because that's what she does. But I am delighted to introduce a member of Secretary's Inner Circle. Pat Powers is here with us today. One of the things that we are doing in California is we are trying to plan beyond the end of the federal funding for health information exchange. And one of the efforts that's helping us do that is a 10-year plan that the governor asked to be put together called Let's Get Healthy California. Pat has oversight of that program and the work groups that have come out from that work. And I was supposed to introduce Secretary, and Secretary was going to introduce Pat. So I don't have a formal introduction for her except to say she's one of the brightest and most brilliant people in California. And if you want something done in healthcare and agency, you ask Pat Powers to take the helm on it. So Pat, would you please fill in until Secretary arrives with us? Thank you. Pat Powers.
Perfect timing.
Guess who's here?
Yes, thank you. Thank you. Sorry about that. It's a busy time. And I know you're all busy as well, and I want just to take a few minutes to welcome you and say how thankful I am for the work that you do. I think I joked with you when I was here last year about how untech or non-tech I am, and how hard it is for me to think about Jamie. Hello. How hard it is for me to think about what it is you do. But I'm very grateful for it, and I like to turn the on button on, and I like to have things work, and I like to be able to say, help, Pam, go get Pam, and figure out what it is we're doing. So we have a very, very big agenda. California, as you know, embraced healthcare reform very early. We had tried on our own before President Obama achieved his historic Obamacare, which I like to say last year, I believed it would not be very long before Obamacare was not a pejorative. It has really never been a pejorative in California. We have embraced it. And many people have understood the significance of better health, better care, and lower cost. And this is certainly putting us on a path to doing that. Much of the attention in healthcare reform has been around coverage expansion. And so when people say exchange, they usually mean the health benefit exchange, which in California is now Covered California. But I know there's another exchange in California, and it's the information exchange. And it, in many ways, is foundational and fundamental to our ability to do any of the other things that we are trying to do. I just finished another interview with a reporter about the progress that we're making, and I always get the question, what keeps me up at night? Or what do I think about at 3 o'clock in the morning? And number one is the IT. Of course, building the kind of system that we're building, and our own Office of Systems Integration, led by Debbie Rose and her team, is just doing extraordinary work in coordination with Covered California and the Medi-Cal department to bring these two very different systems together through one portal. The concept of the Affordable Care Act is that we will have a streamlined eligibility and enrollment process, and it won't really matter on the front side to the user. You'll just go to Covered California and you'll get whatever you're entitled to. But on the back side, these programs are extraordinarily different. We have a private sector insurance product that someone pays for, and we have to sell them. So we have a marketing campaign around persuading people that they are that health security is important, and no one wants to be one illness or injury away from bankruptcy. So they have to buy insurance. And oh, by the way, they're also required to buy insurance. On the other side, there are people at certain income levels for whom this is an entitlement. Medi-Cal, you are entitled to. And so no one ever really has promoted or had to market Medi-Cal, because when someone is sick and they're eligible, they get Medi-Cal. Medi-Cal is retroactive. You go back to the day of the service that you received, and the providers are all engaged with getting people onto Medi-Cal if they're eligible for Medi-Cal. That's not the way with insurance. It's prospective. So we're bringing these two very different products together in one integrated, streamlined enrollment process, and that inevitably leads to a very complicated IT system. And if that weren't enough to have our new CalHERS, which is California, let's see, what does HERS stand for? Eligibility, Enrollment, and Retention. Health Eligibility, Enrollment, and Retention System. That system has to interface with systems that already exist in the counties, because the management and enrollment of Medi-Cal will continue to be a county-based program. We have 20,000 eligibility enrollment workers in the counties that do a very good job. We have 8 million people in Medi-Cal, so we know something about how to get people enrolled and managed in the system. So we've got to bring these systems together, and they come together in your world, which regrettably for me has become my world as well. But the leadership that we have just never ceases to amaze me. The people who step up and work incredibly long hours through very difficult circumstances, and certainly Pam Lane and Debbie Rose are two of my heroes. We've worked very well and very gratefully with the help of Ken Kaiser and the work at UC Davis. You know, he lifted a huge IT transformation at the VA, and so we're very grateful to have Ken's insight and experience. And there are many. There are people all throughout this audience that I could probably name if I knew who you were, but we are all working together to get this very, very ambitious project off the ground. It really is going to be, I think, a 4 or 5 implementation, but there's going to be extraordinary focus on the next 12 months. And so we are here. We are at the launch. We are getting ready. We had another exchange board meeting yesterday. On Tuesday, we will be announcing the grants to the local communities who are going to help us with the outreach and enrollment. On the 23rd, we will announce the successful bidders with our qualified health plans. The rates will be announced at that time. They'll go for review. In July, we will start in earnest to do our marketing for our first open enrollment period this fall. All of that is about coverage expansion, and that is certainly a really important part, and the part that gets the most attention in the Affordable Care Act. But there are really two other legs of the stool. One is delivery and financing reform, and one is wellness and prevention. And in California, we have picked up those batons as well and have moved forward. We recently received an innovation grant from the federal government that we are very lucky to have. Again, Ken Kaiser and Pat Powers and Tom Williams with IHA working with us to look for ways that we can model appropriate behaviors to improve quality and lower the cost through financing systems. And there's a lot of talk about bundled payments and medical homes and accountable care organizations, and there's a lot of innovation that's going on in the private sector, and we want to find some metrics, some ways to measure what's working and what do we want to give special attention to move further faster in the delivery system and financing reform area. And then in prevention and wellness, there isn't a lot of money in the ACA for that, but we have received some of it, and we are working with our partners at the county level to do as much as we can to improve public health and find ways to incentivize wellness and not just treat illness. The fundamental premise of the ACA is to move away from a volume-based payment where we're fee-for-service paying for every encounter to a value-based payment system where we create incentives for providers of health care to actually provide health and to be financially incentivized to keep people healthy rather than simply measure how much sickness they treat. So these are very ambitious goals. It's going to take a long time to do that. And last spring, the governor issued an executive order and empowered me to convene a task force, the Let's Get Healthy California Task Force. And we worked for 6 months. And we did two basic things. We came up with measures. I firmly believe that what you measure matters, and we can't know whether we got there unless we know where we were headed. And so we developed, we ended up with 39 metrics, and Pat's going to go through them for you and explain how we think we're going to get there. But I thought that there were scores of things that are already measured, and there are really hundreds of things that are already measured. So it took us some time to sort through them and move them into categories, and Pat will go through that. And then the second thing we did was inventory innovations, things that are working. I really believe, having spent this part of my career in state service as a bookend to the first part of my career, which in my 20s I worked for this governor when he was governor the first time. And at the end of his second term, we left, my husband and I, Sacramento, and we moved back to what I think the real world in the Central Valley of California, and lived for 26 years in Tulare County, which I often joke, as a Democrat in Tulare County, it was like missionary work. But really good people, really honest, solid stewards of their communities. I was chamber president, I was in the Rotary Club, I was very engaged in the work that people do every day, day in and day out, with making life better in communities. And there weren't D's and R's. We all rolled our sleeves up and we got things done as they needed to be done. So I bring back to my experience in state government now that on-the-ground experience of trying to help government provide the right incentives and get out of the way when we can, to let the right things happen in the right places. And certainly you are at the forefront of that in the work that you do, creating the superhighway for the good things that people want to have happen. It's been very interesting for me as I've begun to get involved with your world, and particularly this intersection of a superhighway for the exchange of information. When I was at the Children's Hospital, they had just built a new building, a beautiful facility when I went there, and very state-of-the-art technology. But that technology didn't interface with anybody else's technology, and as much as they tried, and they had some very really wonderful things, and Jamie Franklin's here, and he can probably tell you all about what they did there, because he was the IT manager when we worked together. But they did have places where referring physicians in the surrounding communities could plug into the vital statistics at the bedside of the kids that they had referred to the hospital. It was just an incredible innovation just 15 years ago. And as I've been more involved now and realized the challenge that we have to make that kind of information accessible is extraordinary. And I think of it as the two biggest impediments are the proprietary nature of the information and the privacy concerns of the people about whom we have the information. And proprietary and privacy are really, really big hurdles. Everybody who buys an IT system, you know, for all of the talk of portability of information, you know, a lot of the providers of care really don't want their patients to have that information all that portable. They would like very much for you to stay in their system, thank you very much. And then, of course, all of us are worried about what is going to happen to that information once it's all aggregated in one place. So the work of the Health Information Exchange, and are you calling it CHEQ? Is that how you say the CHEQ that used to be Cali Connect? The work that you're doing, whatever you call it and however you say it, I know is extraordinarily difficult, but it is important for us to be able to do the measures, to communicate our policies, to gather and know whether we have got gotten to wherever it is we set out to be. So I am very delighted to be with you for a few minutes this afternoon, and very pleased to have my colleague Pat Powers tell you a little bit about our Let's Get Healthy California work and the very ambitious goal we set that in 10 years we want to be the healthiest state in the nation. And I think with the kind of information that you can help us share with each other, we can certainly be there. So best wishes for your conference, and thank you. Thank you all very much.
Thank you, Secretary Dooley, and thank you, Pam. I didn't bring my flip-flops, but I reserve the right to step out of my heels and be in socks on the stage if I get tired of standing here. So what I'd like to do is talk just for a few minutes about the state's vested interest in population health. And this slide depicts the different lenses that you can look through. So the state has a role in health and healthcare as a trusted caretaker. Government officials are concerned about the health of all Californians. The state has an interest as a purchaser of care. Secretary Dooley talked a bit about Covered California and Medi-Cal and the substantial investments in these programs, as well as CalPERS. Similarly, on behalf of all purchasers in the state, the government has an interest in ensuring that our economic environment is viable for businesses. One of my first positions out of graduate school was for the Small Business Administration, and we did the first study showing the correlation of health insurance and size of firm. And it's every year since the early 80s, I'm dating myself, health costs have been at the top agenda for the business community, escalating cost. The state also is a regulator of health and healthcare and has a vested interest in ensuring that our system works properly and ably, serves its clients, and is financially solvent. And last, the state is a guardian of public health, ensuring that we do all we can to detect and prevent disease as early on as possible. So these differing roles in health and healthcare mean that we need population information at various levels. And you can see from this slide, we need to be able to telescope. We need to look across the state. We want to drill down at the county level. The public health community is very interested in drilling down at the census tract, zip code, or neighborhood level. On the healthcare side, we tend to look at the level at which we're purchasing care or the way that the services are delivered. So purchasers tend to look at the payers as a population, at hospitals as a population, and medical groups as a population. So the point here, and to build on what Secretary Dooley just said, we're facing skyrocketing cost. I mean, the trend has pretty much gone up, even though it's slowed a little bit in the past few years. Chronic conditions and diseases are also escalating. And how do we try and temper that with innovations as we're expanding access at the same time? So I'm going to talk about Let's Get Healthy, but before that I'm going to share with you a little bit about our state innovation model design grant that we just were awarded from the Center for Medicare and Medicaid Innovation. And I know this slide has a lot on it, so I'm going to break it down. But essentially the grant is a 6-month grant from April through September to develop a state healthcare innovation plan to transform care delivery. So the ACA is primarily known for access right now, but there are a lot of pieces in it, and the federal government is moving very quickly in helping states experiment with payment reform and care transformation efforts, and California is one of those states. We're hoping after the 6-month period that we will be eligible for a testing grant that would be tens of millions of dollars, between 20 and 60 million, over a 3-year period, where we need to demonstrate a net return on investment for our proposed payment reform recommendations. So this first slide is really the vision statement. How can we be home to the highest quality and most efficient healthcare system in the country? Under that, we have the triple aim, which everyone is looking toward both nationally and statewide. And then this is a draft, but our committee has started talking about what are our goals as a state. We want to reward value in innovation, at the same time improving quality, at the same time promoting care coordination in our fragmented system, create transparency, and foster competition. As part of our Let's Get Healthy work, we set a target 10 years from 2012. So in 2022, we want to see the rate of growth in health expenditures not exceed that of the rate of growth of our gross state product. If we are going to implement our innovation plan, we'll need to set a target for 2016 in terms of where we want to see health spending as a state. And this is the initial framework we're developing. I think it's a work in progress. I don't know if any of you heard on the news this morning, as I was driving here, NPR was doing a story on the fact that Medicare just released the top hospitals in the country, actually all hospitals in the country, the top 100 DRGs and their billed charges. Now, many of us in this room know that billed charges aren't very meaningful, but I think it is a step forward in terms of transparency, and directionally that is where the big purchasers, Medicare, in addition to the commercial sector, in addition to Medi-Cal, want to go over time, and the consumer. So many consumers are faced with high deductibles, high coinsurance, significant copays, that they're starting to think about costs for the first time. I personally just enrolled recently in an individual policy that had has a $6,000 deductible, not in total, but for in-network and out-of-network. And every year that deductible kicks in. It terminates at the end of the year. So that's what consumers are facing right now. How are we going to help them in terms of making decisions around cost? How do we as purchasers, how does the state as the biggest purchaser figure out how we can improve cost, breaking it out by the way that our state is organized in delivering care? So we've got HMOs or managed care as well as fee-for-service. As I showed on the initial slide, we want to be able to look at geography. We want to be able to look at top episodes or diagnoses, similar to what Medicare has just released on top conditions for hospitals. And then we also need to look at quality and outcomes and population health. So each of the buckets in this framework are going to require a significant amount of work. We've made progress, but we still have a long way to go. And we're working together with the private sector. We've got various work groups going on that are looking at different goal areas, which I will share with you in a moment, about what innovations do we think are most promising. The evidence is rather thin, but there are some, California being the innovative state that it is, has some very promising payment reform solutions that we want to look at on a broader level if we took them out. So just by way of example, we want to look at the high-risk, medium-risk, and low-risk populations. We want to look at things like patient-centered medical homes for complex patients, perhaps bundled payments for select conditions, and how can we keep healthy people healthy and prevent them from getting chronic conditions. So I'm sharing this with you because health information exchange is absolutely critical in helping us figure out, A, what are the most promising strategies and how would they apply to our state, and B, we're going to need, as we implement them, timely information all along the way. If you're familiar with Dr. Don Berwick, our former CMS administrator, in his Institute for Healthcare Improvement, he had a model, Plan, Do, Study, Act, PDSA. And the study part is where we need data so that as we're implementing, we can look and see, are we on track? Are we having the effects that we think we have with our strategies? So again, some of the building blocks. In our approach for the State Health Innovation Plan, we may be looking at enabling legislation. We touched on, Pam touched on workforce this morning, and we already have bills in the legislature making their way through talking about workforce issues. We're asking providers and payers whether there are any regulatory impediments that they face. And again, health information exchange, especially the first goal that you've set forth as your initiative to enhance individual and population health outcomes through results-oriented programs, dovetails perfectly with this initiative. So I was talking with Lynette Scott earlier about, so when we talk about HIE, are we talking just about quality and outcomes? Because I think that's certainly important and relevant, but what about claims? Are we talking about cost here? Because we need both pieces of the equation. And I think that's to be continued as a discussion, but we want to be able to link the electronic clinical information, and we need administrative data for both care coordination as well as on the cost side. So what are we trying to measure right now with respect to population health, and what do we have in our toolkit today? As Secretary Dooley mentioned, last year she and Dr. Berwick co-chaired a very robust task force of leaders throughout the state, leaders in health, leaders in healthcare, leaders in education, employers, researchers, a very diverse group of people. And of course, everyone had their favorite topics and pet issues that they wanted to put into our framework, given the hundreds and hundreds of possible measures that are out there. So after many meetings and surveys and discussions, this is what we came up with. So we wanted to answer Secretary Dooley's question of how can we demonstrate that California is the healthiest state in the nation. And we came up with 3 segments across the lifespan. The first is Healthy Beginnings, looking at the health of children and adolescents. The second, Living Well, preventing and managing chronic conditions. And the third is End of Life. And many people are especially pleased that Secretary Dooley is stepping out on this topic, given its historical controversy with respect to the ACA, because it's very important from the consumer individual perspective. And so we're looking at these 3 pathways. I'm going to just quickly show you some indicators for them that we're using to see whether or not we're successful 10 years from now. And then we developed 3 ways in which we think we're going to make progress on this continuum. So the first is redesigning the health system to be efficient, safe, and patient-centered. The second is creating healthy communities, enabling healthy living. And the third is lowering the cost of care, making coverage affordable, and aligning financial incentives. And the 6 work groups that I mentioned that have been going on since December are focused around these 6 topic areas and deliberating on what are the best strategies for California to be implementing in each of these 6 areas. I also want to mention health equity, which is a critical aspect, and it's so important that we decided it shouldn't be its own goal, it should cut across all goals. So again, when you think about HIE, are we able to produce information around race, ethnicity, language, or in some instances other demographics like income, geography, and age, so that we can get a sense of what populations we need to be focusing our resources on in terms of improving health. So quickly, just to say a few words about each of these. I'm not going to read all of the indicators to you, and I will make the slide deck available. Healthy Beginnings, we have 13 indicators. I think that's, this is the heaviest bucket in terms of indicators. And you can see the array of priorities that we want to measure over time. And I just quickly kind of looked at our appendix in the back of our report, which is available on the HHS website. And I'm going to highlight a couple that are automated already. Many of these indicators are survey-based. And so part of, I think, the question we all should ask ourselves over time is, can some of these surveys be turned into electronic data so that they're more readily available in a more timely way, in an easier way? Can they be integrated with other patient data? The first item, infant mortality, is from the Vital Statistics Query System. And number 6, childhood asthma, is from our OSHPD, Office of Statewide Health Planning and Development database on ED visits for asthma. Our second goal area, living well, preventing and managing chronic disease, is a very significant category given the growth in people with chronic conditions in California. Almost all of the indicators in this bucket, including self-reported health status, fitness and healthy diets, et cetera, are from survey-based data sources. 2 of them, under controlled high blood pressure and high cholesterol, which are NCQA metrics, are from administrative data sources. Our third goal area, which is end of life, one of our work group's recommendations is that we need to develop more metrics for this topic area. But the ones that the experts have recommended that we included in our Let's Get Healthy framework are hospitalization during the end of life, which we want to decrease, and palliative care and hospice care. And then we're hoping to develop a measurement on advanced care planning. So both number 24 and number 26 that get at the hospitalizations during the end of life and increasing palliative care and hospice care come from Medicare claims data that have been analyzed. So it's not something that's their regular reports on. They were Dartmouth Atlas and California Hospice and Palliative Care Association conducted these analyses. So I think we're going to be looking at ways that we can make these more regular or more routine reports. And then our fourth goal area, redesigning the healthcare system to be efficient, safe, and patient-centered. You can see what the priorities and metrics are here. 3 of the indicators, 29, 30, and 31, which are hospital-focused. We tend to have our best data from hospitals. That comes from OSHPD, using AHRQ metrics on quality and patient safety. And then our 5th topic, which is creating healthy communities. These data are primarily from national sources, CDC, National Transportation Survey information, and our California Health Interview Survey data. So again, kind of, we need to look at ways that we can more easily measure these kind of things through administrative data. And then the last one, lowering the cost of care, making coverage affordable, and aligning financing to health outcomes. These are primarily survey-based, and some of them we can't measure at all. I talked a little bit about transparency and the need for information on cost and quality for consumers, for purchasers, and for the state overall. And we don't have a good way to measure that right now. We have a handful of quality metrics on the OPA website. Other states have struggled with how to do this, and by today's indicator, Medicare is moving in that direction as well. So I think all of us are going to work in partnership to figure out how we can get to more transparency on this goal in particular. So I hope I've provided some useful information on the context by which you all work, and I'm happy to answer any questions along with Secretary Dooley. But I wanted to just provide a perspective on the different dimensions of population health. It depends on who's doing the looking, what is the population you want to measure, and how can you telescope up and down for those measurements. Thank you.
you think so, or do
you want-
we just?
we just go
we
back
can
and
just
forth?
take it. We'll just take your questions.
I'll stand down here.
Okay.
And
What would you like?
We have microphones. We have about 13 minutes or so for questions. I believe there are some microphones out in the audience, and Jim, our audio tech, is gonna help us.
We have a question back here.
We have questions. Yes, sir.
I'm an internist, director of cardiopulmonary department for 25 years. At a recent meeting of the American College of Physicians up in San Francisco, a senior Mayo Clinic cardiologist reviewed advances in outcomes in cardiac care and made the case that the vast majority of the statistical improvements were due to changes in tobacco use and laws. Now, we have a governor who says he's not going to sign a tobacco tax increase. And you could make a case that that's very anti-health and not very wise. And I hope that you'll carry the message back that we need help from people like him to advance health in California, regardless of other silly considerations.
Message received.
At least he doesn't have a...
Yeah, Pat said at least we don't have a cigar tent. Other questions? Yes.
Good afternoon. My name is Maricel Brown. I'm here from the Alameda County Public Health Department, and I have a question about healthy communities. I noticed that you have safe communities as an indicator. However, I didn't see anything about education. We know that a child who's not reading at grade level by grade 3 is most likely to drop out of high school, as well as have a number of other negative socioeconomic consequences. Is there any interest in adding an education indicator?
It's actually there, but it's on a different slide. It's on the Healthy Beginnings. It's one of our indicators for Healthy Beginnings, and it is precisely the indicator that you just described, reading level of proficiency at grade 3. Yes.
I just have a comment. I know you mentioned the palliative care, how they got the statistics on deaths, and I'm not sure if they're using the code for the V66 for the palliative care. They're actually looking at hospice admits. So I would just look at that data a little more careful to see whether it's dependent on a coder to code it correctly or how they have come up with that stat.
And Pat may be able to answer the specific question of how that's created, but your point is well taken for most of the quality indicators. I worked when I was in the hospital industry with the chart, the effort to get quality indicators, and there is so much burden on chart review to get the information and have it be apples to apples. It's very challenging, and so making that data more uniform is one of the things that we recognize that we need. And Pat may have a different answer.
I'm Michael Marchand with UC Davis. One of the things that I looked at the metrics that you've put up there is that it's all behind historical, or it's based on claims data. So with the efforts on health information exchange and the efforts here, how often are you going to go back and make adjustments to those metrics in relation to that real-time data that will be available?
Well, deciding which metrics was a huge challenge, and as Pat said, you know, we really had hundreds, and you may have noticed in some places we decided that something we wanted to know about was worth including even though there wasn't yet a measurement tool for it. So there are a handful of the 39 that we have agreed we are all going to work to try to find an appropriate measurement tool for that. But getting the historic data that we have is really the only place we can start. I don't know, Pat, if you have. a better answer.
Yeah, I think just like everything in health and healthcare is dynamic, and I think the measurement process, when it started over 20 years ago, has come a long way. And as changes are made, as our ability to risk adjust, for example, has advanced, then they're incorporated into that process. So I think we've recognized that this report was produced at a particular point in time, but we want to keep it fresh and up to date as we're able to do that.
I'm Chris Esguerra with San Mateo County, and I'm a psychiatrist in the behavioral health department, and I'm very happy to see the mental health well-being as aspects of all of that through the lifespan, as well as tobacco use being monitored. What I'd also like to advocate is also monitoring for alcohol use and those effects, as we all know that it affects not only health but the rest of the community.
We have a question down front.
One more?
Microphone.
Okay.
Yeah, I do just want to point out that California's tobacco use is one of the lowest in the country right now, in part due to the good work of the state and taxes, prior taxes.
Gwen Marie Hillary with the San Diego Beacon Project. We are building wonderfully strong information pathways to exchange information in healthcare between providers. But there's an important moment in that success, and that's asking the patient if they're willing to share their information. And in most models that I come across, we're asking that information of the patient when they come to see the provider. But the fact is, most people are not in doctor's offices. Is there any room at the state level to have legislation similar to that the legislation we used with donors and the donor question for organs being asked with the driver's license, to have a similar question or similar model for us with health information exchange, either with driver's license or voter registration or other public vehicles? Are we open to doing that in the state of California?
Well, I don't know is the state open to that. I haven't heard that idea, so I think it'd be worth exploring and talking about. I heard a similar issue with respect to a physician who's doing fabulous work with medically complex patients in a patient-centered medical home, and they opt into this program, but they still maintain their primary care, which may be in a different medical group. And he said, I cannot access the record unless the patient is with me physically. And it's a barrier. So how can we create secure messaging, and how can we ensure patient permission and privacy? So I think we'd have to look at HIPAA and all those good laws.
Well, and it seems like there was an issue even with Cali Connect on the opt-in, opt-out, whether or not someone's information was automatically included and they had to affirmatively disallow it, or whether you had to get permission from, for every use from every patient. So privacy is very complicated. I think we have time for one more question over here.
Most of the states that do have, the opt-out situation get 97 to 98% of patients in that HIE, and they have an effective healthcare system. The others that have tried opt-in are below 75%, and they don't find it very effective. So again, messages to Jerry Brown and the legislature. Thank you.
Right. There was a very robust discussion about that had gone on in the previous administration with the Cali Connect board, and Lynette can probably give you more information about that history. She was right in the eye of that storm, and she may have comments about it. But I do want to comment about the national data. When I started with this task force a year ago, I had as a goal to be the healthiest state in the nation. But to be the healthiest state in the nation, we have to have some comparative basis. We've got to compare to something. And there is virtually no uniform database anywhere. There are so few things that are collected in the same way across all the states that it is very, very difficult. So I went back to my old advertising and marketing years. You know, I started my career as a lobbyist. That's what I did for Governor Brown. I was his lobbyist, and then I had a public relations and advertising agency for 10 years, and then I went to law school. So I always say the downhill slide finally stopped. But in those marketing and advertising years, there is sort of advertising license that you can take where you say you're the best at something and you don't really have to prove it. And so I came to the conclusion that to say we're the healthiest state in the nation, if we're a lot healthier in 10 years than we are today and we can demonstrate that, I'm not going to have any problem standing up, although I will tell you for sure I will not be here in 10 years. And I hope somebody that can stand in my place and say that indeed California has an arguable or colorable claim to being the healthiest state in the nation, but it won't be, regrettably, on the basis of comparative data with all the other states, I fear. Thank you all very much, and best wishes for your program.